Right now, millions of older adults are taking medications that doctors have prescribed for decades. These drugs sit in medicine cabinets across the country. They treat pain, inflammation, depression. They're FDA approved. They're considered standard care. But emerging research is revealing something deeply concerning. Three classes of commonly prescribed medications are causing measurable cardiovascular damage in people over 60. And cardiac surgeons are starting to speak up. Dr. James Rodriguez, a cardiovascular surgeon at a major teaching hospital, recently shared an observation that's being echoed by his colleagues nationwide. Over the past decade, I've noticed a disturbing pattern, he explained at a recent cardiology conference. Patients who should have relatively healthy hearts for their age are coming to us with unexpected damage. When we review their medication histories, the same drug classes keep appearing again and again. The research backing up these clinical observations is substantial and growing. Major studies involving hundreds of thousands of patients are now documenting cardiovascular risks that weren't fully understood when many of these drugs were first approved. Recent research has found that certain medications increase heart failure risk by 48 to 85% in older adults. Other studies show dose-dependent increases in heart attacks, strokes, and dangerous heart rhythms. The most concerning aspect? Many patients have no idea these risks exist. They take their medications faithfully, trusting that their doctors have considered all the risks and benefits. But medical knowledge evolves, and new research on antidepressants shows a 56% increased risk of sudden cardiac death after 1 to 5 years of use, with even higher risks for longer exposure. This isn't about creating panic or encouraging anyone to stop medications without medical guidance. It's about informed decision-making. It's about understanding what the latest research shows so you can have meaningful conversations with your healthcare providers about whether the medications you're taking are truly the best options for your individual situation. The average American over 65 takes 4 to 5 prescription medications daily. Many take 7 or more. Each of these drugs was probably prescribed for a good reason at some point, but how often do doctors systematically review whether each medication is still necessary? How often do they consider whether newer, safer alternatives might work just as well? The answer, unfortunately, is not nearly often enough. Before we dive into the specific medications, take a moment to comment below with your age and where you're watching from. We read every comment, and your engagement helps us understand who needs this information most. Are you currently taking any medications for chronic pain, inflammation, or mood disorders? Drop your comment now. Then let's get into the 3 drug classes that cardiac specialists are most concerned about. Number 3. Gabapentinoids, gabapentin and pregabalin. You probably know these drugs by brand names like Neurontin and Lyrica. Gabapentin and pregabalin are prescribed for nerve pain, shingles, fibromyalgia, and sometimes anxiety or insomnia. Their use in older adults has skyrocketed. Prescriptions have increased by over 600% in the past decade, making these among the fastest-growing medication classes in geriatric medicine. For years, doctors considered these medications relatively safe alternatives to opioids. As the opioid crisis intensified and physicians faced increasing pressure to reduce opioid prescriptions, gabapentinoids seemed like the perfect solution. They could treat pain without the addiction risks, overdose dangers, or regulatory scrutiny. Insurance companies were happy to cover them. Patients reported feeling better. It seemed like a win-win situation. But then the long-term data started coming in. A major 2025 study published in JAMA Network Open analyzed data from 246,237 Medicare beneficiaries and found that pregabalin users had a 48% increased risk of heart failure compared to gabapentin users. Even more concerning, for patients with existing cardiovascular disease, pregabalin was associated with an 85% higher risk of heart failure. That's not a small increase. We're talking about nearly doubling the risk of one of the most serious cardiac conditions. Pregabalin caused roughly 6 additional heart failure events annually for every 1,000 patients treated. When you multiply that by the millions of people taking this medication, we're talking about tens of thousands of preventable heart failure cases every year. But even gabapentin isn't without concerns. Research from Denmark found that gabapentin increased the risk of heart failure by 14% over a 5-year period, while pregabalin increased it by 20%. The mechanism involves calcium channels in heart cells. Both drugs bind to voltage-gated calcium channels throughout the body, not just in the nervous system. Pregabalin has a stronger affinity for binding to these channels than gabapentin, which explains why it causes more severe cardiovascular effects. In the heart, this calcium channel interference disrupts the normal regulation of sodium and water. The kidneys retain more fluid, blood volume increases. The heart has to work harder to pump that extra volume through the circulatory system. Initially, the heart compensates by enlarging slightly and pumping more forcefully, but over months and years, this compensation fails. The heart muscle becomes stretched and weakened. Eventually, the heart can no longer pump effectively, and heart failure develops. What makes this particularly insidious is how slowly the damage develops. Heart failure doesn't announce itself with a dramatic event. It creeps up gradually. You might notice you're more tired than usual, but you attribute it to getting older. You might find that climbing stairs leaves you more winded, but you figure you're just out of shape. You might need extra pillows to sleep comfortably because lying flat makes you feel short of breath. Meanwhile, your heart is struggling. Fluid is backing up into your lungs. Your legs are swelling. Your kidneys aren't getting adequate blood flow, so they're retaining even more sodium and water, creating a vicious cycle. By the time heart failure is diagnosed, significant damage has already occurred, damage that may not be fully reversible even if the medication is stopped. The tragedy is that many patients taking gabapentinoids don't even get significant benefit from them. A comprehensive review in the BMJ found that these drugs provide meaningful pain relief for only about 30 to 40% of chronic pain patients, yet side effects occur in up to 60% of users.
But alternatives absolutely exist. For nerve pain, duloxetine has shown similar effectiveness in clinical trials without the same cardiac concerns. Topical treatments like lidocaine patches deliver localized pain relief directly to affected areas without systemic effects. Physical therapy and targeted exercises can address underlying biomechanical problems that contribute to chronic pain. If you're currently taking gabapentin or pregabalin, this is absolutely worth discussing with your doctor. Don't stop suddenly. Withdrawal from gabapentinoids can cause serious problems, including seizures in some patients. Tapering needs to be done gradually under medical supervision. But do schedule an appointment specifically to discuss your cardiovascular risk profile. Ask your doctor, given my age and cardiac risk factors, does the benefit I'm getting from this medication justify the increased risk of heart failure? Are there safer alternatives we could try? The American Heart Association currently lists pregabalin but not gabapentin as a medication that may cause or exacerbate heart failure. This distinction should factor into treatment decisions, especially for patients with existing heart disease. But as concerning as gabapentinoids are, the next medication class poses even broader cardiovascular dangers, and it's one that millions of older adults depend on for inflammatory conditions. Number 2. Corticosteroids, prednisone and related drugs. Corticosteroids like prednisone, methylprednisolone, and dexamethasone are powerful anti-inflammatory medications. They treat conditions ranging from rheumatoid arthritis to inflammatory bowel disease to severe asthma to autoimmune conditions like lupus. During acute flare-ups of inflammatory diseases, they can genuinely be life-saving. But when it comes to long-term use in older adults, the cardiovascular consequences are severe, well-documented, and far more serious than most patients realize. A landmark study published in PLOS Medicine examined 87,794 patients with immune-mediated inflammatory diseases and found strong dose-dependent increases in all types of cardiovascular disease. After 1 year of treatment, patients taking less than 5 milligrams of prednisone daily, what doctors traditionally considered low-dose therapy, had a twofold higher absolute risk of cardiovascular events compared to non-users. Even at doses that many physicians consider low and safe, cardiovascular risk doubles. For patients taking more than 25 milligrams daily, the absolute risk of cardiovascular events was sixfold greater than for non-users. The risks included heart attacks, heart failure, atrial fibrillation, stroke, peripheral arterial disease, and abdominal aortic aneurysm. During follow-up, 13,426 patients developed cardiovascular disease. That included 6,013 who developed atrial fibrillation, an irregular heart rhythm that dramatically increases stroke risk. It included 7,727 who developed heart failure, and it included 2,809 who had acute myocardial infarctions, heart attacks that can be fatal or cause permanent heart damage. These aren't small numbers or rare complications. This is widespread, measurable harm occurring in a substantial percentage of long-term steroid users. The cardiovascular damage from corticosteroids happens through multiple interconnected mechanisms, creating a perfect storm of cardiac risk. First, there's blood pressure. Corticosteroids cause dose-dependent increases in blood pressure through several pathways. They increase the sensitivity of blood vessels to naturally occurring chemicals that cause constriction. They cause the kidneys to retain sodium and water, expanding blood volume. Over time, this sustained elevation in blood pressure damages the delicate inner lining of arteries, accelerates plaque formation, and forces the heart to work much harder than it should. Second is the effect on cholesterol and lipids. Corticosteroids cause dyslipidemia, characterized by increased LDL cholesterol, the bad cholesterol, and increased triglycerides, while simultaneously decreasing HDL cholesterol, the good cholesterol. This lipid profile is a recipe for accelerated atherosclerosis. Third is glucose metabolism. Corticosteroids cause insulin resistance and can push pre-diabetic patients into full-blown type 2 diabetes. Diabetes is one of the most potent risk factors for cardiovascular disease. Fourth is the weight gain. Corticosteroids increase appetite dramatically and cause the body to redistribute fat toward the abdomen and trunk. Patients often gain 15 to 30 pounds within the first year of therapy, and this weight tends to settle around the organs in the form of visceral fat, the most dangerous type for cardiovascular health. Perhaps most concerning is the direct effect on heart structure. Research published in Circulation Heart Failure used advanced cardiac MRI imaging to study patients on long-term corticosteroids. These patients showed significant left ventricular hypertrophy. The heart muscle was becoming abnormally thick. They also had reduced cardiac output and signs of diastolic dysfunction, where the heart becomes stiff and can't fill properly between beats. A particularly alarming study from the Netherlands followed 68,000 patients for an average of 9 years. Current corticosteroid users had an 83% increased risk of heart failure compared to never users. Even more concerning, patients who had used corticosteroids in the past but weren't currently taking them still had a 32% elevated risk, suggesting that the cardiac damage persists even after the medication is stopped. So, what's the solution? For many patients, corticosteroids sometimes are truly necessary. The goal isn't to eliminate their use entirely, but to use the minimum effective dose for the shortest possible time while aggressively managing the cardiovascular side effects. For many patients with conditions like rheumatoid arthritis, disease-modifying anti-rheumatic drugs like methotrexate can control inflammation without the same cardiovascular profile. Biologic medications like tumor necrosis inhibitors, Humira, Enbrel, Remicade, offer targeted immune suppression with generally better cardiovascular profiles than corticosteroids. For conditions like asthma, optimizing inhaler technique can make a dramatic difference. Studies show that up to 70% of patients use their inhalers incorrectly. Working with a respiratory therapist to perfect inhaler technique can often reduce or eliminate the need for systemic steroids. When corticosteroids are truly necessary, minimizing the cardiovascular impact requires aggressive management of side effects. This means monitoring blood pressure closely and treating any elevation promptly. It means checking blood sugar regularly and intervening early if prediabetes or diabetes develops. It means dietary counseling to prevent excessive weight gain. Medical experts now recommend that patients requiring oral glucocorticoids should be treated with the minimal dose required while being closely monitored for cardiovascular risk. Some experts recommend that any patient over 60 who's been on corticosteroids for more than 3 months should have a comprehensive cardiac evaluation, including at minimum an electrocardiogram.
But as dangerous as corticosteroids are to cardiovascular health, there's one more drug class that cardiac specialists find even more concerning, particularly because it's so widely prescribed, and patients frequently take these medications for years or decades without anyone fully explaining the cardiac risks. Number 1. Certain antidepressants, tricyclics, and extended use. This is the medication class that generates the most concern among cardiac surgeons. Antidepressants are among the most commonly prescribed medications for older adults, with usage rates exceeding 20% in people over 65. They treat depression, anxiety, chronic pain, insomnia, and various other conditions. Many patients have been taking them for years or even decades. The cardiovascular risks vary significantly between different classes of antidepressants, and recent research has revealed some truly alarming findings about long-term use. Let's start with tricyclic antidepressants, TCAs, like amitriptyline, nortriptyline, and doxepin. These older medications are still widely prescribed, especially for nerve pain, migraine prevention, and insomnia in elderly patients. A study following nearly 15,000 people in Scotland found that tricyclic antidepressants were associated with a 35% increased risk of cardiovascular disease. Research examining sudden cardiac death found even more disturbing results. Current users of TCAs had a dose-related increase in risk, with rate ratios increasing to 2.53 for doses of 300 milligrams or more. That's more than a doubling of sudden cardiac death risk at higher doses. The mechanism involves multiple cardiac systems. Tricyclics affect muscarinic receptors, leading to decreased parasympathetic activity. That's the rest and digest part of your nervous system that normally keeps your heart rate reasonable and maintains healthy heart rate variability. When this system is suppressed, heart rate increases and heart rate variability decreases. Reduced heart rate variability is a powerful predictor of sudden cardiac death. Tricyclics also affect cardiac ion channels, prolonging the QT interval on an electrocardiogram. When this interval becomes too long, the heart becomes vulnerable to a dangerous arrhythmia called torsades de pointes. This can rapidly degenerate into ventricular fibrillation, leading to sudden cardiac death within minutes. But here's where the research gets even more concerning, and this applies to all classes of antidepressants, not just the tricyclics. A 2025 study presented at the European Society of Cardiology examined all deaths in Denmark in 2010 and found that individuals with a history of antidepressant use had an increased risk of sudden cardiac death that varied based on age and duration of exposure. For people aged 30 to 39, 1 to 5 years of antidepressant use was associated with approximately 3 times higher risk of sudden cardiac death, increasing to 5 times higher for those with 6 or more years of exposure. For people aged 60 to 69, 1 to 5 years of antidepressant use was associated with a 56% increased risk of sudden cardiac death. This research included multiple classes of antidepressants, not just the older tricyclics. While selective serotonin reuptake inhibitors, SSRIs, showed no increased cardiovascular risk in some shorter-term studies, this longer-term exposure data on sudden cardiac death is raising new and serious concerns. There are important caveats to understand. Depression itself is an independent risk factor for cardiovascular disease and sudden cardiac death. The relationship between antidepressants and cardiac risk is complex. It's difficult to fully separate the effects of the medication from the effects of the underlying depression. However, the dose-dependent relationships and duration-dependent relationships seen in the research suggest that the medications themselves are contributing to the risk. If it were purely the depression causing the cardiac problems, you wouldn't expect to see such clear patterns where higher doses cause more cardiac events and longer duration of use causes progressively higher risk. Some SSRIs carry specific cardiac concerns. Citalopram, Celexa, and escitalopram, Lexapro, have dose-dependent effects on the QT interval. In 2011, the FDA issued warnings that citalopram should not be prescribed at doses above 40 milligrams daily and no more than 20 milligrams for patients over 60, specifically because of QT prolongation concerns. SSRIs also increase the risk of gastrointestinal bleeding, particularly in older people taking aspirin, clopidogrel, or blood thinners. Studies show a 42% increased risk of serious bleeding events in SSRI users. For patients on dual antiplatelet therapy after heart stents, adding an SSRI increases bleeding risk by 79%. So, what's the solution? The key message isn't that depression shouldn't be treated. Untreated depression itself poses serious cardiovascular risks. Rather, it's about choosing the safest approach for each individual patient and regularly reassessing whether medications started years ago are still necessary. For people with coronary heart disease who do need antidepressant medication, sertraline is considered the first-line choice among SSRIs, with fluoxetine, Prozac, and paroxetine as alternatives, as they have fewer known cardiac side effects. Mirtazapine, Remeron, may be suitable for people with heart disease and has the advantage of not increasing bleeding risk the way SSRIs do. But medication shouldn't be the automatic first choice, especially for mild to moderate depression. Cognitive behavioral therapy has been proven to be as effective as medication for many patients with depression, with zero cardiac risk and lower relapse rates after treatment ends. Exercise programs have demonstrated remarkable antidepressant effects while simultaneously improving cardiovascular health. Multiple studies show that regular aerobic exercise, even moderate intensity walking for 30 minutes most days of the week, has antidepressant effects comparable to medication for mild to moderate depression. Addressing underlying medical causes can sometimes resolve depression without adding another medication. Hypothyroidism commonly causes depressive symptoms. Vitamin D deficiency is extremely common in older adults and contributes to depression. Vitamin B12 deficiency can cause both depression and cognitive problems. Sleep disorders like obstructive sleep apnea frequently cause depressive symptoms that resolve when the sleep disorder is treated. For patients currently taking antidepressants, particularly tricyclics or high doses of citalopram or escitalopram, this is absolutely worth discussing with your physician. Don't stop suddenly. Antidepressant withdrawal can cause serious problems. Tapering needs to be done gradually under medical supervision. Ask these specific questions. How long have I been taking this medication? What were the original reasons for starting it? Are those reasons still present? What are the cardiovascular risks given my age and heart health? Are there safer alternatives? Request an EKG if you haven't had one recently, especially if you're taking tricyclics or higher doses of citalopram or escitalopram. Ask about your bleeding risk if you're on blood thinners.
The research suggests that long-term antidepressant use should be periodically reassessed rather than automatically continued indefinitely. Your heart deserves this conversation. The path forward, taking control of your heart health. If you've made it through all of this information, you're probably experiencing some combination of concern, confusion, and perhaps frustration. These medications were prescribed by trusted doctors. They're FDA approved. How can they carry these serious cardiovascular risks? The answer involves the evolution of medical knowledge. Most medications are approved based on clinical trials that last weeks to months, occasionally a few years. But what happens with 5, 10, or 20 years of continuous use?
Those long-term effects often don't become apparent until millions of people have been taking the medication for extended periods. The research we've discussed, showing heart failure risks from gabapentinoids, cardiovascular disease from corticosteroids, and sudden cardiac death risks from long-term antidepressant use, is relatively recent. Much of this data has emerged in just the past 3 to 5 years. But here's what matters most. This information gives you power. You now understand that 3 common drug classes pose real cardiovascular risks in older adults that need to be weighed carefully against their benefits. This doesn't mean you should panic or stop your medications tomorrow. Stopping gabapentinoids suddenly can cause seizures. Stopping corticosteroids abruptly can trigger a life-threatening adrenal crisis. Stopping antidepressants suddenly causes severe withdrawal symptoms. These medications must be tapered under close medical supervision if discontinuation is appropriate. What this means is that you need to have informed, honest conversations with your healthcare providers. Here's how. Schedule a dedicated medication review appointment. Don't try to have this conversation during a brief visit. Call your doctor's office and say, "I'd like to schedule an appointment specifically to review my current medications and discuss cardiovascular risks." Come prepared with specifics. Bring a complete list of all your medications, including doses and how long you've been taking each one. Document any cardiac symptoms you've noticed: fatigue, shortness of breath, dizziness, palpitations, swelling. Write down your questions in advance. Frame your concerns constructively. Start by acknowledging that your doctor prescribed these medications for good reasons. Say something like, "I've been reading recent research from 2025 showing increased heart failure risks with pregabalin, and I'm concerned given my age. Can we talk about whether the benefits still justify the cardiac risks?" Ask specific, pointed questions. Don't let the conversation stay vague. Ask, "What is my specific cardiovascular risk? Have you seen the 2025 JAMA study? If we continue this medication, what monitoring should we put in place?" Don't accept dismissive responses. If your doctor says "don't worry about it" without engaging with the research, push back politely but firmly. Consider getting a second opinion. If your primary care doctor dismisses your concerns, consider consulting a cardiologist or geriatric medicine specialist. What to do starting today. If you're taking gabapentin or pregabalin, schedule an appointment to discuss your cardiovascular risk and explore alternatives. Ask about duloxetine for nerve pain or topical treatments if your pain is localized. Watch for signs of heart failure, including progressive fatigue, shortness of breath, and leg swelling. If you're taking corticosteroids, ask your doctor about disease-modifying drugs or biologic medications that might allow you to reduce steroid use. Ensure that your blood pressure, blood sugar, and cholesterol are being monitored regularly. If you've been on steroids for more than 3 months and are over 60, request a cardiac evaluation. If you're taking antidepressants, evaluate whether you still need the medication. Ask about cognitive behavioral therapy or other non-pharmacological approaches. If you're on a tricyclic or high-dose citalopram or escitalopram, ask about switching to a safer alternative. Request an EKG to check your QT interval. For everyone, create a complete medication list. Schedule annual medication reviews with your doctor. Know your cardiovascular risk factors: blood pressure, cholesterol levels, blood sugar. Be alert for cardiac symptoms and report them promptly. Your heart deserves better. Your heart has been beating faithfully for you every second of every day of your entire life, roughly 100,000 beats per day, over 35 million beats per year. It deserves protection. It deserves informed decisions. The pharmaceutical industry and healthcare system have failed to adequately communicate these cardiovascular risks to patients, but you now have information that changes that dynamic. You understand the risks. You know what questions to ask. You know that alternatives exist. After reading all of this, I'm genuinely curious. Do you feel empowered to have these conversations with your doctor, or are you worried that bringing up these concerns might damage your relationship with your healthcare provider?
This is a real psychological barrier that many patients face, but that model of healthcare is outdated and potentially dangerous. The best healthcare outcomes happen when patients and doctors work as true partners. Your doctor works for you, not the other way around. You hire them to provide medical expertise and guidance, but ultimately, decisions about your body and your health are yours to make. Drop your thoughts in the comments below. Tell us your age, what country you're in, and whether any of these 3 drug classes are part of your daily routine. Share your experiences, your concerns, your questions, and your plans moving forward. If someone you care about is taking any of these medications, please share this information with them. The research is clear, the risks are real, the alternatives exist, and informed patients who ask the right questions can make better decisions about their cardiovascular health. Thank you for taking the time to read this entire article. Your health matters, your concerns matter, your heart matters, and your willingness to ask tough questions and demand better care might literally save your life.